So let's talk for a few minutes about the issue of incentives in physician payment systems. These can be really important for understanding how we got some of the challenges we've gotten and how we're going to be able to address them in the future. Any kind of physician payment method in general, will generate some sort of incentives, and the payment systems we've been looking at are no different. Payments based on fee-for-service will tend to create an incentive to do more services or more expensive services. On one hand, this might help ensure that doctors have incentives to do all the things that patients might need. That might be a good thing. On the other hand, people sometimes worry that fee-for-service might create an incentive that would lead to overuse of care, maybe doing more than we need to do, leading us to spend more than we need to spend. Now, it's probably not fair to say that most physicians are entirely focused on maximizing their practice revenue by doing as many services as possible when they're paid fee-for-service. But physicians are people too, and incentives can matter. Often I find it useful to think of this as a subtle, but maybe not zero effect. Medical care has many options for treatments. One can do a bit more, one can do a bit less. Using the expensive option sometimes is an option, and sometimes you can also choose the less expensive option. When patients tend to want more done, and physicians might be interested in doing that, fee-for-service would only reinforce the move to do more. The physician will get paid for doing more, so there's one less reason not to. Economists and others who've studied this say that in fact, fee-for-service does look like part of the cause of rising costs and might in fact promote overuse in some circumstances, leading us to do more than we need, and so there's been a lot of attention to this issue. Capitation, on the other hand, goes the other way. Here, physicians have an incentive to do less for each patient, right? They've received a fixed payment, and they'll do better financially if they incur fewer costs by providing less care. This might be good too. It might incentivize them to seek the most cost-effective ways of providing care, and they might ignore those under fee-for-service. But then one might also worry about overdoing it and ending up with underused care, not doing things that would be beneficial. One might think of salaries as a solution to this, and indeed they might have a more neutral set of incentives with respect to how much care to provide. But we also have to note that it's not always possible to use salaries to pay physicians. Salary models really only work well when physicians are employed in larger practices. However we design our payment systems then, we need to think about incentives and the associated impacts on the healthcare system. There has been a ton of attention to how to manage this, and people are trying all sorts of creative and interesting new things. You might run a fee-for-service system, but with some efforts to monitor care and try to steer people toward not overusing care as best you can. You might do the same thing with capitation. Use a capitation system, but deliberately design some interactions with providers or some monitoring to try and make sure that underuse doesn't happen. And some people have tried hybrid models sometimes. If you use capitation for many things, but pay fee-for-service for particular types of care that you're worried about underuse of, maybe that's a solution. So you can pay attention for this. There's a lot of attention to the incentives associated with different payment systems and how we can manage the direction of the push created by the systems that we use.